Check 1, 2, 3. Check, check, check. Okay, I think we'll get started. It's my pleasure to introduce Dr. Heather Stefanski, who is an assistant professor in the Department of Pediatrics. What she will be discussing more this morning is immune reconstitution after allogeneic bone marrow transplantation. But as all of you know, the goal of hematopoietic stem cell transplantation is the replacement of diseased or damaged bone marrow. And the first successful bone marrow transplant took place here in 1968, so 50 years ago, almost 51 years ago, when that occurred. And what's interesting is actually listening to some of the terminology that's used in this video clip. What I'm going to show you is that this was filmed back in 1968, right before the first patient underwent a transplant, and it's an hour-long video. I'm showing you only 1 minute of it. However, this was performed by Dr. Robert Good back in the late 60s, and his interest was in immune reconstitution, focused specifically on immunodeficiency diseases, for which this first patient had. But let me just show you this brief video clip. Some of it is, I wish I could actually go into different parts so that you can actually see some of the things that were being done and some of the funny aspects that we would never consider today, but I will talk about that in a second.
David's story actually starts 1,300 miles away at the University of Minnesota Medical School in Minneapolis, where for 20 years, intensive research using various kinds of animals has been leading up to a new concept in medicine: cellular engineering, the replacing of missing cells due to a genetic defect. Specifically, the transplanting of healthy bone marrow cells to fight infection.
Well, I just want to summarize for you some of the decisions that were made at the Geneva Conference on the immune deficiency diseases.
Pioneered by March of Dimes grantee Dr. Robert A. Good, world-renowned immunologist, this new approach to correcting inborn errors of metabolism is the most exciting recent step in the fight to correct birth defects, a tragedy which strikes 250,000 babies every year in America.
Everybody is in agreement that the
birth defects are not always apparent in the newborn, as was the case of David Camp that day in 1968 at the Meriden, Connecticut hospital.
Well, certainly I could continue that, but some of you, the buildings you recognize, you may have actually even sometimes recognize some of those historical figures. However, I thought it was quite interesting when they used the term cellular therapy, because that's a common term now used, not only for treating patients by allogeneic bone marrow transplant, but also using now their immune cell subsets as a way of treating various diseases, like curing patients with refractory acute lymphocytic leukemia by genetically modified T cells. So cellular therapy is certainly an emerging field that we've been interested in for quite a long time, but it's really now hit the public domain in a much more broad way. But as all of you know, particularly some of you in the audience, infectious disease complications represent a major cause of treatment failure in the setting of transplantation, primarily because of the profound immune deficiency state that occurs. When we do an allogeneic transplant, we're also doing a reconstitution of immunity. And so that process takes quite a long period of time, and there's a number of factors that influence the speed of recovery, namely the type of conditioning that we use, the age of the patient, the HLA mismatch between the donor and recipient. But all those things combined actually conspire to increase the chance that the patient will have some type of complication as a result of very severe opportunistic infection. We see things like rhizopus, mucor, as well as aspergillus, and also other types of gram-negative and gram-positive and reactivation of viruses, which represent major causes of morbidity, if not mortality. So Dr. Stefanski's goal is to figure out ways of bridging this immune reconstitution so that we can reduce some of these major side effects. So it's my pleasure to introduce Dr. Stefanski, and the title of her presentation is Improving Immunity Post-Transplant. Thank you.
Thank you. Okay, let's see if I can do this. Okay, so thank you, John, for that very nice introduction. Before I get started, I do have some disclosures. I am a consultant for both Novartis and Jazz Pharmaceuticals, but I'm not going to be discussing this at all during my presentation. So I have 3 objectives. One is for you guys to come away with an understanding that what the manifestations are post-transplant of the immune system, to understand how T-cell immunity impacts relapse and infection, and to understand how umbilical cord blood can be used to improve the immune system. So as John just showed, the history of bone marrow transplant was really done at the University of Minnesota, where the first successful related donor allogeneic stem cell transplant was done in 1968. And last year we celebrated our 50th anniversary, which was pretty fun to have patients come back and tell us their stories. The first successful unrelated donor transplant was done in 1973, and that was performed at Memorial Sloan Kettering. So the principles of transplant are that we deliver chemotherapy plus or minus radiation, and the reason for that is we want to either get rid of bad cancer cells like leukemia or lymphoma, or we want to make space in the bone marrow, and we also want to immunosuppress the recipient. And then when we're doing transplants, we do it for a couple of reasons. One is, as I said, to replace the immune system for cancer, or we're also trying to help with genetic disorders such as Hurler syndrome or adrenoleukodystrophy, epidermolysis bullosa, or bone marrow failure syndrome such as Fanconi anemia. And so the way that we do this is we take donor cells from a healthy donor. So there's a number of complications from transplant. It's not done without really taking into consideration what the other alternatives are. We would never give a transplant to anybody that did not need it. And mainly it's because there is increased morbidity and mortality due to the infections. Patients also, when they receive an allogeneic transplant, have a risk of graft versus host disease. And there's also organ toxicity that goes along with it, which is why we're lucky to have so many specialists to help us. So hematopoietic stem cells, they're blood-forming cells that can duplicate by self-renewal, as well as produce all types of differentiated blood cells. So the stem cell can produce red cells, white cells, and platelets, which is what it needs to do. There's certain characterizations of it. So one of them is that it is CD34 positive. This is a marker on the cell surface that we use for flow cytometry. They're also c-KIT positive. And the way that when we look at a transplant, we want to know how many cells we're going to be giving a patient, because if the patient doesn't get enough stem cells, then the graft won't work. And so there's ways that we evaluate the number of stem cells, and this is all based on what the recipient's weight is. So there's the nucleated cell count. The acceptable dose is between 2 to 4 times 10 to the 8 nucleated cells per kilo. And then we also look at the CD34 cell count, which is the acceptable cell dose is 2 times 10 to the 6 per kilo. So umbilical cord blood is another stem cell source. So we can either use bone marrow, we can use peripheral blood stem cells, which we typically don't do in children because there's an increased risk of graft versus host disease. But we use umbilical cord blood, and Dr. Wagner is one of the really one of the leaders in this field. So in 1988, the first umbilical cord blood transplant was performed that was related for Fanconi anemia by Elian Gluckman. And then in 1993 and 94, the first unrelated cord blood transplant was done by Dr. Wagner. So the beauty about umbilical cord blood is that it can be stored for long periods of time. It's taken from the umbilical cord bloods and placentas at birth, so there's no risk to the baby. The target dose is a little bit lower than what we can get from the bone marrow or the peripheral blood. And the target's 1.7 times 10 to the 5th CD34 cells per kilogram. So in thinking about what happens after transplant, my focus has really been how to expedite immune recovery. So the reason for that is when a patient gets a transplant, it takes up to a year for their immune system to become acclimated to the new donor cells. And so patients have an immune system to a newborn baby. So essentially, after a year after transplant, then we actually revaccinate the patients just as we would a newborn baby. T-cell immunity is not fully functional. And why do I care about T-cells? Well, T-cells are really the critical cell post-transplant that will fight viruses and fight fungus. So although we have good antiviral medications and good antifungals, they're truly not adequate for patients to be able to fight these infections. And if a patient has graft versus host disease, then we have to further immunosuppress them and further immunosuppress their T cells so they're not functioning. So when that happens, these patients are truly at risk of infection. The T cells have two components. There's a CD4 helper T cell component and then a CD8 cytotoxic T cell component. Both of these are very important, and they're both immunosuppressed. And then the other issue is that if you don't have T cells, then you can actually have these functional responses to pathogens. So when Juliet Barker was here in the early 2000s, and umbilical cord blood transplantation was just really up and coming, they wanted to look at what was the risk of infections in patients that had umbilical cord blood compared to other types of stem cell sources. So they looked at patients that at our institution with hematologic malignancies and then looked at infections early on post-transplant, so in days 0 to 42 or later, days 43 to 81. And they looked at 3 different stem cell sources. So they looked at unmanipulated bone marrow, they looked at T cell depleted bone marrow, and then umbilical cord blood. So in the early transplant period, what you can see here is that patients that had T cell depleted bone marrow had much higher risk of viral infections or incidence of viral infections compared to those patients that had unmanipulated bone marrow and those patients that had umbilical cord blood. And then more importantly, in the later times after transplant, patients that had T cell depleted bone marrow had higher risk of both bacterial infections and viral infections, and then total infections overall. So what this data showed us was that although there had been concerns perhaps that because umbilical cord blood is so naive and that patients would have higher risk of infections, this wasn't the case, but also that when you get rid of T cells, that those patients are really at high risk of infections. In another study by Parkman in 2006, what they wanted to look at is they wanted to look at umbilical cord blood transplant recipients' ability to respond to antigens. And so the way that they did this is they took T lymphocytes from transplant recipients and then tested these cells in vitro against certain herpes viruses. So they tested it against CMV, HSV, and varicella. And interestingly, what they found is that they could then discriminate between those patients that were able to have a functional response to pathogen and those that weren't. And what they found from this is that patients that had a positive response to pathogens, meaning that their T cells were functional, were that these patients had less probability of relapse after transplant. Whereas those patients that had a negative response, meaning that they were unable to respond to these viruses, that those patients had a higher probability of relapsing. So again, taken together, this shows that T cell functionality after transplant is critical, not only for fighting infections, but also for cancer patients and preventing relapse. So there's a number of factors that affect reconstitution of immunity. So one is the graft source, so umbilical cord blood, bone marrow, peripheral blood. The source characteristics, the cell number of that, whatever that stem cell source is based on the recipient's weight, and the naivety of the source. Then nowadays, we're actually able to manipulate the graft. So we can do T cell depletion, as I talked about. We can actually do CD34 selection as well. And then now we can do alpha beta T cell receptor depletion. Host factors are also a factor, so age and prior therapy. So in some of my patients that have had, perhaps they've had a solid tumor and then they relapse with a secondary AML, those patients have higher risk of a normal immune, or not having a normal immune system because of all of their prior therapy and what it has done to the bone marrow. And then there's also transplant-associated complications. So graft versus host disease, as I previously mentioned, these patients have to be further immunosuppressed, and that means then that they're at higher risk of infection. And then the conditioning and graft versus host disease regimens that we use, sometimes we use Campath. Campath is a monoclonal antibody that is able to get rid of both T cells and B cells, but these patients have profound T lymphopenia for a long period of time after transplant. We also use ATG, which is anti-thymocyte globulin, which gets rid of the T cells as well, and those patients are also at risk of a poor immune system. So where do T cells come from after transplant? So within the allograft, there are hematopoietic precursors. So these hematopoietic precursors are very smart. They have a homing device that basically forces them to go to the bone marrow where they make their niches and they start producing the red cells, white cells, and platelets, and they also produce the T cells. Now, T cells need to get educated in the thymus, so the T cell precursors then home to the thymus where they then become naive T cells. Within that allograft, there are also T cells that are non-alloreactive, meaning that they're not going to react to the new donor cells. These cells can undergo homeostatic T cell clonal expansion, and that's because of all of the, basically the revved up milieu of cytokines that are seen after transplant that can cause these T cells to become activated and expand. Within that allograft, there's also alloreactive T cells. So these are the cells then that can also undergo T cell clonal expansion because of the cytokines that are there. And these are the ones that we don't like because they can cause graft versus host disease. Within the host, there's also residual host T cells, which we don't like either, because they can also undergo alloreactive T cell clonal expansion, and they can cause graft rejection because they don't like the donor cells. So ideally, what you want is you want the naive T cells to make up the predominant pool, but there's also going to be these other homeostatic T cells that are there. So there's a number of barriers that are causing our inability to be successful with immune reconstitution. So one of them is there's a lack of T cell precursors in the bone marrow. So with whatever stem cell source that you're giving, whether it's umbilical cord blood or bone marrow or peripheral blood for that matter, there's not enough T cells to really get a good T cell immune system. And then the other issue is that the thymus, with all of the chemotherapy and radiation, in order for the T cells to become educated, the T cells need to interact with the stromal cells that are in the thymus. And these are affected by the chemotherapy and radiation. And it takes them a long time to recover. So the thymus isn't normal after transplant. And then the other issue is that there is chemotherapy and radiation can also affect the lymph nodes and the spleen, but the lymph nodes are really the critical organ where functional responses take place, and so the lymph nodes are also affected by the chemotherapy and radiation. What I'm going to focus on today is how to get more T cell precursors to overcome that barrier. And the thought behind that is that if there's not enough T cell precursors and the stroma is injured, perhaps you can overcome both of those by giving more T cell precursors to help with the stromal injury. So the way that we do this is we are using OP9-DL1 cells, and this is a mouse stromal cell line that expresses Notch1 ligand delta-like 1, which has been shown to be critical for T cell development. So when you culture these cells in vitro with mouse hematopoietic stem cells, there's large numbers of pro-T cells that are generated. And when these are infused with bone marrow into the mouse, there's an increase in thymic cellularity, normal T cell repertoires, and then increase in donor chimerism. So the way that we first wanted to do this, we wanted to recapitulate the system in our lab. And I started doing this with Bruce in 2008 when I was a fellow. So we took hematopoietic stem cells from a mouse. You culture them with IL-7 and FLT3 and put them on the adherent OP9-DL1 layer. You can culture them for between 0 and 35 days. And then we're going to look at what the pro-T phenotype is. Now, before I go over what that is going to look like, I first want to get us thinking about the thymus. So the way that it works is that the early thymic progenitors will come in at the cortical medullary junction, so looking at where that blood vessel is, and then they're going to undergo this very defined, differentiation. So they're initially DN1s, and this is based on looking at CD44 and CD25, which are two surface cell markers. So DN1s are CD44 positive and CD25 negative. And as they go to the outer edges of the cortex, they become DN2s, which now they're going to express both CD44 and CD25. And as they're in the outer cortex, they then lose the CD44 expression and become CD25 only. Then they become DN4s, and then they become a double positive cell for CD4 and CD8. And that's it's at the double positive cell where the cell undergoes positive selection in the cortex, and this ensures that they have a functional T cell receptor. These double positive cells then go out to the medulla, where they then undergo negative selection, and what this ensures is that the T cells will not be autoreactive or self-reactive. And so the T cells are, the microenvironments within the thymus are very defined, and in order for the T cells to undergo selection, these processes need to happen. So basically what we're taking is a mouse hematopoietic stem cell and then seeing what happens. So initially we started at 200,000 cells, and then by day 25 we got 465 million. So they underwent quite a huge expansion. And then looking at what the cells look like, so initially they didn't express any T cell markers, and the DN1 or the CD44 positive population was the predominant population at day 7. And then by day 10, the predominant population is DN2, and there's quite a few DN3s. And then by day 21, the cells are predominantly DN3. So you can see that in vitro, we're recapitulating what would have happened in vivo in the thymus. So then the next question would be, do these cells work in vivo? So the way that we do this is we take hematopoietic stem cells, put them on the OP9-DL1 cells, culture them for 21 to 28 days, and the predominant population, as I just showed you, is DN2 and DN3. Then we transplant these into a mouse, and we irradiate the mouse, and then we add congenic bone marrow, because if you don't add the congenic bone marrow, the mouse would die because it needs hematopoietic precursors. And then we look at thymic engraftment. And we're able to define each of the populations based on a certain cell marker that they have. So this is what the pro-T cells look like that were injected. So you can see that they're predominantly DN2 and DN3, where 85% of the population was DN2 and DN3. And then we could actually see pro-T engraftment as early as day 7. So looking at a normal mouse, a B6 mouse, so this didn't receive any transplant, the pro-T cells are on the x-axis, and the donor bone marrow is on the y-axis. And so in the B6 mouse, there's nothing there. In the bone marrow only, there's a little bit of bone marrow that you can see. It's still pretty early. And then looking at the pro-T cells, those cells were 18.4%. So looking in the mouse at day 7, we can already see T cell engraftment in the thymus. And then the other question would be, so if they get to the thymus, are they able to undergo normal thymic development? And what would, as I just showed, what would happen is that they'd become these, the double positive cells, which truly is the predominant population in the thymus. The thymus looks like an eagle. And it's based on CD8 and CD4. And so looking at the wild type mouse, you can see that there's the predominant population, there's CD8 and CD4, or they're the double positive population. And then I was able to differentiate between the host and the donor based on what their markers are, and then looking at what did the development look like. And so the important thing is that the pro-T cells, which is shown in this lower corner here, although they came in as early thymic progenitors, or DN2 and DN3, they were able to differentiate into the double positive cells. So they're able to undergo the normal thymic selection processes. Yes? Oh, thank you. thank you. So then this is looking at the cell numbers of the thymocytes. So this is a normal B6 mouse, and then these are the components. So in the bone marrow only, you can see that there's no pro-T cells. And then in the pro-T plus the bone marrow, the predominant, or about 50% of the population is actually the pro-T cells. So again, that the pro-T cells were able to engraft. So the conclusions from this were that pro-Ts improve immune reconstitution and are able to engraft the thymus. So the next thing that we wanted to do is ask, could we translate this to humans? So can we generate human pro-T cells? So the way that we wanted to do this is we wanted to take umbilical cord blood, and now it's obviously different than the mouse. So here we're looking at CD34 positive cells, which we isolate, and then we place them on the mouse stromal cell line, and we culture it with human IL-7, human FLT3, and then human stem cell factor. And you can culture these on the OP9 cells for between 14 and 21 days. And then we would inject these into immunodeficient mice. So this is looking at frozen umbilical cord blood, and they were able to expand. However, where the expansion was not as great as we saw with the mouse hematopoietic cells. So here we started with, about the same amount, maybe 200,000, and we were only able to get about 16 million cells from the umbilical cord blood. The next question was, do they have a normal T cell phenotype? So the first marker that's on a T cell is CD7, and then CD5 is a later marker. So in the upper graphs, we're looking at CD34 and CD7, and then in the lower graphs, we're looking at CD5 and CD7. So here, what you can see is that the predominant population at day 10 expresses both CD34 and CD7, and then as we go on, they lose some CD34 expression, but there's still a large population that are CD34 and CD7 positive. And then looking at these cells, pro-T1s are CD7 positive, CD5 negative, and pro-T2s express both CD7 and CD5. So that is the more mature T cell. And you can see at the end of the culture that the predominant population is CD7 and CD5 positive, or the pro-T2 cells. So then looking in the mouse, this is where a mouse that only received hematopoietic stem cells alone. And then this is a mouse that received 250,000 pro-T cells, and then the other graph is looking at 1 million cells. And the average compared to the hematopoietic stem cell alone was basically 300,000 to 200. And this is showing the NSG mouse, and in the NSG mice they have no thymus, and in the forceps here is the thymic lobes. So sorry if you're eating breakfast and that makes you sick, but that's a little thymus. So it was able to work. Now, the issue with this is that we were able to generate large numbers of pro-T cells, but in a clinical trial, we need 100 million cells. And this just wasn't going to be feasible with one cord blood unit. So the options would be we could use multiple cord blood units, but first of all, that's really expensive, and that may not necessarily be great for the patient, because what is the risk of graft versus host disease if you're giving all these different T cells? And so with this, at the same time that we were thinking of this, Dr. Wagner, along with Novartis, was trying to overcome a stem cell barrier. And the reason for that is that when we are looking at different stem cell sources, in the time to engraftment, which means when do the neutrophils come in, when you compare this to peripheral blood mismatched or matched, peripheral blood comes in around day 13. And then when you're looking at bone marrow that's either mismatched or matched, those cells start to engraft around day 18. When you look at umbilical cord blood, there is a delay to 25 days. And so the issue with that, you could say, well, that's not that long. It's, maybe a week. But when you think about what could happen during that week, and the patient is at risk of infections because they don't have any neutrophils, and this means longer hospitalizations and other issues, they wanted to overcome that barrier. And so the thought was, how do we expand stem cells in vitro? So there's a number of strategies that could be used. cytokine combination mediated expansion, co-culture with stromal cells, notch signaling pathway that induced expansion, or a small molecule that induced expansion, which is what we chose, the aryl hydrocarbon antagonist. So there was a trial going on that looked at the safety of giving large numbers of these cells, because they could generate essentially billions of these cells. And so the way that this trial went is that it was a double cord trial. So with they were both within 2 antigen mismatches. And then they're based on what the number of the cords were. If the smaller unit underwent the expansion. And the way that that happened is that the CD34 cells would be isolated, and then they would be put in culture to expand them. Now, in that umbilical cord blood unit, there's also CD34 negative cells. So those cells were frozen and saved for later. And so the patient essentially received 3 products. They received an unmanipulated or uncultured umbilical cord blood unit. They received the expanded umbilical cord blood unit, and they also received the CD34 negative. And then this was a dose capping trial, and the primary endpoint was safety, basically measured by the absence of infusional toxicity and graft failure. So what you can see is that in patients that actually engrafted with the expanded unit, they engrafted at 10.5 days. And so this was much better than the 25 days. And so a couple of the other questions or the important things to think about, though, is that when you're giving this massive amount of cells, how would the patients fare? Would they have worsening overall survival? Could they have more transplant-related mortality when you're giving all of these cells? Or really, could they be getting more graft versus host disease? Although you're only expanding the stem cells, and it's the T cells that cause graft versus host disease, you still would worry about that. And the bottom line is, as shown in all these graphs, is that when we compare it to the historical controls of umbilical cord blood transplant, that there was no difference in grades 2 to 4 acute graft versus host disease, no differences in grades 3 to 4 acute graft versus host disease, no differences in the transplant-related mortality, and no differences in the overall survival. And so our thought then was, okay, if we're able to generate this large number of basically stem cells, could we use this as a source of pro-T cells? And so our approach then was to, again, take a cord blood unit, isolate CD34 cells, but now we're going to expand this with cytokines and SR1 for 15 days. We then take that bulk population and put it on the OP9DL1 cells and culture them for between 14 and 21 days, and then we inject the pro-Ts into the irradiated mice. So when we looked at just the expansion alone, SR1 is shown in blue, and the naive umbilical cord blood is shown in black. And you can see that we were now able to generate large numbers of cells, which is what we would need to do for a clinical trial. So whereas with the naive umbilical cord blood unit, we could only generate 25 million, between 15 and 30 million, I should say, now we're able to generate in the 200 million range. So then what does the phenotype look like? So at day 7, looking at CD34 and CD7, they haven't really made T cells yet because there's not a lot of CD7 cells. But the predominant population here would be of the T cells would be the CD34 positive cell and CD7 positive cell. And then as we go on in culture, you can now see a large population of CD7 positive cells. And then interestingly, by the end of culture, they lose their CD34 expression. And so this was different to the naive umbilical cord blood because here, although it wasn't the predominant population, there was still a large population of CD34 positive, CD7 positive cells. And the reason that we were concerned about this is because the dogma at the time was that you needed CD34 on the T cell in order to engraft the thymus. So if we're generating the cell in vitro and it's lost all of its CD34 expression, what does that mean? So we tested it in our model, and we took pro-T cells with hematopoietic stem cells. This is looking at, and and we compared it to naive umbilical cord blood, meaning it was unmanipulated. And then this is looking at what the T cell population looks like. So they're pretty similar where they're pro-T2 cells. That's the predominant population where they express CD5 as well as CD7. And then in mice, this is looking at the thymus now in this graph. So in mice that didn't receive any T progenitors, nothing happened. And then comparing 200,000 to 500,000. So the white bars are naive umbilical cord blood. The black bars are SR1 expanded cord blood. And you can see that they were able to engraft. Now the naive umbilical cord blood was able to engraft better at the higher doses, which could be related to the fact that they had CD34 on their cell surface. And then when we looked in the periphery, both cells were actually able to make it out into the periphery and become T cells. So this is looking at the thymus and looking at CD8 versus CD4. So naive umbilical cord blood and then SR1 expanded cord blood, both of them are able to engraft the thymus. And then this is just looking at the flow plots from the periphery. So you can see that there's human cells that are in the periphery from both naive and the SR1 expanded cord blood. So we really wanted to get to the bottom of this. And so what we did is we sorted CD7 positive cells and then based it on, and we sorted CD34 positive, CD7 positive, and CD34 negative and CD7 positive, and then tested these cell populations in vivo to see what would happen. And interestingly, in the sorted SR1 cells, looking at CD45, which is a human marker, the CD34, CD7, you can see that they engraft the thymus, but also the CD34 negative, CD7 positive also engraft the thymus, albeit at lower numbers. And they also are able to undergo normal thymic development, meaning that although they were at the pro-T2 stage, they still were able to become double positive cells. So both in the CD34 positive, CD7 positive, and the CD34 negative, CD7 positive. And although when you have CD34, or when the thymocyte has CD34 on the cell surface, they're able to engraft better. But regardless, we were still able to get engraftment. Interestingly, when we take naive umbilical cord blood and do the same experiment, naive CD34 negative cell, CD7 positive cells don't engraft. So there's something functionally different with whatever we do with the expansion that allows these CD34 negative cells to engraft. So our conclusions from this were that SR1 expanded cord blood results in much larger numbers of pro-T cells. The SR1 expanded pro-Ts lose CD34 expression, but they're able to engraft, and that there's this fundamental difference. So my final thoughts are that slow immune reconstitution causes significant morbidity and mortality in our patients. In order to overcome this, we need to expedite the immune recovery, and hopefully we're going to be able to do this with the pro-T cells. And right now we're scaling this up at the MCT facility in order to prepare for the clinical trial. So what we're doing right now is we have a phase 2 trial that's going to be the predecessor to the pro-T trial. And so right now, this is similar to the initial expanded trial, except it's only with one umbilical cord blood unit. And what we're doing is we take one umbilical cord blood unit, we isolate the CD34 cells, we cryopreserve the CD34 negative cells, and then we put the ex vivo culture with SR1. The patients then get flu-cy TBI as part of their prep. And then this is a phase 2 trial, so right now we're looking at the incidence of neutrophil recovery by day 14. This trial just opened up this year, and I think we already have 10 patients at least on this trial. The other thing that we're doing with this, in order to get a better idea of what the immune system is going to look like, is we're going to vaccinate earlier. So typically our transplant patients are vaccinated at a year post-transplant where they get basically all of the baby vaccines, and then they go and they have to get boosters and things like that, and we don't give live viral vaccines until 2 years post-transplant. But we wanted to look at what the immunity is a little bit earlier. So what we're going to be doing is at day 60, we're going to test the patients for serologies, and they're going to receive both Pediatrics and Pneumovax. And the beauty about Pediatrics is it has Hep B, polio, pertussis, diphtheria, and tetanus. So they're going to be vaccinated for a lot of different pathogens. At day 100, we're going to test the patients for the serologies. At day 120, they'll receive their second dose of vaccinations at their home institution, because hopefully they're at home by then. And then at day 180, we'll be testing them again for serologies, and they'll receive their third dose of vaccinations. So with this trial, then we'll be able to understand how patients do. And with the Pro-T trial, which hopefully is going to be starting next year, what we're going to be doing is we're going to be taking just one umbilical cord blood unit. We're going to do a CD34 selection, and then those CD34 positive cells are going to be put in vitro for 15 days, like we do. The cells then, at the end of that, part of them are going to be frozen, and then part of them are going to be going into T progenitor culture. With this, we're also going to use deuterated water, and the reason that we want to do that is because you can take a blood sample from a patient, and by MRI, you can actually test to see which cells were made from the Pro-T cells. So the patient's going to undergo the same chemotherapy and radiation, so Cy/Flu and TBI, and then at day 0, they're going to be getting a frozen product, so the frozen CD34 expanded product. And then on day 14, they're going to be getting a fresh Pro-T product. This first trial is going to be a phase 1 trial where we're going to be looking at basically the safety of infusing this, and it's going to be a dose escalation trial. So we'll start at 1 times 10 to the 6th and go to 10 times 10 to the 6th. And so it's very exciting that finally all of this work is hopefully coming to fruition. All my acknowledgments, so John Wagner and Bruce, Beverly Norris, and Bob have been very helpful with the Center for Translational Medicine in helping me with this work. And then in translating this to the MCT facility, Dave McKenna, Darren Sumstead, and Diane Kadidlo. And then Jasti Singh and JC Zuniga Fluker have been very helpful with doing some of the NS, or my Pro-T work, with the NSG model, and then Jan is my postdoc. So thank you.
That was really wonderful, Heather. My question is, what percentage of your patients might respond to vaccination in your pre-transplant trial, looking at the various vaccines? I don't anticipate that some of your patients are going to be responsive at all.
I would anticipate most of them won't be responsive, but I think it'll be good to know we need a baseline. And if we truly want to see if T-cell immunity is functional after transplant, I think that's the best way to do it. We can also test this with tetramers. I didn't go over all the other nuances of it, but we're also going to be testing different T-cell populations as well.
As I pass the microphone to Joe, nice talk, Heather. Quick question. Can you say a little bit more about the SR1 protein? What sort of a protein is it, and could it be developed into a pharmaceutical product in its own right, and thereby obviating the need to pre-treat the cells ex vivo?
Well, it's an aryl hydrocarbon antagonist, and actually I don't know what's being, I don't even know if John can say what's being done with it.
Aryl hydrocarbon antagonist, what does it do? What's its mechanism as a protein?
Yes, so I can answer that. So this particular molecule is playing a role in the differentiation pathway. It actually is blocking the differentiation pathway that normally occur in hematopoietic or lymphoid subpopulations. And so if we gave this in vivo, it probably would have a detrimental effect. I mean, it would actually probably perhaps enhance the risk of leukemia because it blocks differentiation. One of the important things that we wanted to make sure of before we did the clinical trial was that it was reversible, that it did not bind to the cell and that, or actually be taken up by the cell and actually not be able to get rid of the drug. So we wanted to be able to wash it out before we put it into patients. So it's the retinoid pathway. It's a very well-described pathway of cell differentiation, and it just happens to block differentiation, or at least partially block differentiation to allow uncommitted progenitors to increase in number.
So thank you, Heather.
question about the applicability of this outside of stem cell transplant to other chronic immunosuppressive states, whether it be organ transplant or a new AML induction, where they're going to be knocked out for,
So ideally, the beauty about giving these cells is that they have to be educated in the thymus. And so I envision that this could eventually be an off-the-shelf product that you would be able to give to patients because they would it undergoes normal thymic selection processes. So ideally then, the cells that have a functional T cell receptor would be positively selected, and those that are autoreactive would be negatively selected. So I do see that could be used. And then I also see where you could also give a CAR T cell, so a chimeric antigen receptor T cell, put that in the pro T cell, and then that would allow those patients that had leukemia to also have T cells that would be functional and then would also be able to bind to whatever residual leukemia they have.
I think one of the statements, or something you might describe a little bit about is one thing that might be discussed a little bit about is that this is an example of translational medicine where we're developing something in the laboratory and applying it to people. Can you tell us a little bit about the process? I mean, for example, you're using OP9DL1, so this is a murine fibroblast or a stromal cell line. And why would the FDA allow you to inject murine cells into a patient? Because not all of them will be removed by the culture methodology.
Yes. So it has been a process. That's the nice way to put it. And so there's a number of things that we've been trying to do. One of the issues is that it is a mouse stromal cell line, which when we had a pre-IND meeting with the FDA actually wasn't that worried about it, but they were worried about some of the other things. But what we're worried about is that when the way that we have had to scale this up is that, so I initially did this in a petri dish or a flask, and the way that you get the cells off is you basically use vigorous pipetting, for example. Well, the way that they do this in the MCT facility, because you can't have hundreds of flasks, for one thing, that could bring in contamination issues when you have to go into the cultures all the time. They use basically these things called stacks. And so you don't get the vigorous pipetting. You can't do that. And so now what we have to do is we actually have to trypsinize the entire thing. And so then what we're getting a lot more of this mouse stromal cell line. And so what we're doing now is we're trying to figure out ways to get around that. So one way that we're trying to do is we're actually going to try to phycol the product. Bruce brought this up last week to see if the debris would just fall off, because it really is debris. It's not functional cells that are there. Another way that we could do this is we could do a selection stage where we CD45 select, because CD45 is found on all lymphocyte cell surface. Yeah. And so we could do a CD45 selection to try to get rid of the OP9 cells that would be there. Or we could try to get rid of, use a mouse kit that really just attaches to mouse cells. And so that would be more of a negative selection. And so it's all of these things that come up basic. I mean, we've had to pivot a number of times where, with the first umbilical cord blood, we're never going to generate enough cells. So we pivot to the SR1 expanded cells. Well, they have a completely different phenotype. Is that going to be okay? Luckily, it was okay. I mean, if it wouldn't have been okay, I don't know what we would have done at that time. But then now we're trying to figure out, okay, what is going to be the best product that we can give to patients that's also going to be really safe? And so ideally, it'll be less than, 5% or 1% of what we're actually infusing into the patients.
Heather, nice talk. My question is about the future clinical trial coming up, hopefully next year. Which patients do you envision using?
So we'll be using this for adult patients. This won't be allowed in kids, and it'll be patients with hematologic malignancies. So similar to what we're doing for the current trial, although the current trial allows anybody up to age 55. So here we would say ages 18 to 55 with hematologic malignancies, and those patients would have to undergo the chemotherapy and radiation. We wouldn't want to vary that piece as we're doing this.
So the one thing that Brenda and Joe do is that they give chemotherapy over and over and over again. And so what happens to the thymus when we see the patient? Because the thymus seems to be an important part of, why these cells might actually get educated and actually work. And then in addition to what Joe and Brenda do, we give Cytoxan, fludarabine, and high doses of irradiation. What happens to the thymus and, will it work?
Well, that's a good question. I think that the thymus can rebound, and and I feel like by giving a lot of pro-T cells will actually expedite the immune recovery better, because that will help the thymus recover. Because you need the interactions between a large number of T cells and the stromal cells in order for that, basically the thymus to rebound. And so I anticipate that if we're giving this large number of pro-T cells, that would expedite the thymus. But that could be a problem. Yeah.
Good going, Joe and Brenda.
You blame it on us.
Okay. Thank you. Okay. Yeah.
In adults, so as people age, their thymus is not as functional.
Yeah.
So it's not good. So that means that the T cell, after transplant, in adults, the T cell function is not as good as kids because they're not undergoing.
Thank you.
Sorry, I'm back. Because they don't have that thymus education.
Yes, that's true.
Okay, and that's something for managed, because thymus will
Right.
rebound.
Oh, that's an easy question. Oh, thank goodness. I love these
I was
easy
curious
questions.
because I'm a neonatologist. I just wanted to say thank you because my high school girlfriend is getting a bone marrow transplant and she's being evaluated this week to be in this trial.
Oh, she is?
Yes. So thank you. Me too. But thank you. I said she sent out, her caring bridge thing.
Everything looks like
And
got goosebumps.
yes. So thank you.
Sorry.
Thank you. No, yeah. I'm going to show you this.
Yes.
So her caring bridge site. So read this.
rheumatology to
Right here.
transplant oncology. The viral load means something. And it ain't true. There's just no data. And so, and I cringe.
You have been disconnected from the meeting.